Good evening. My name is Ken Dix, CEO of Life 365, and welcome to Season 2, Episode 3 of The New Normal. Today, we'll be talking about hospital at home, increasing access to care. Before I introduce our panelists this evening, I want to take a minute and thank all the healthcare providers, first responders, school teachers, family caregivers, vaccinators, and many others helping us through the current COVID-19 pandemic. Thank you for all your service. I also want to let you know that everyone will be on mute and that we will accept questions via chat, and we'll try to entertain a few questions throughout the webinar. Tonight's webinar will be posted on life365.health website or thenewnormal.buzz tomorrow, along with the audio being available on Apple and Google Podcasts and many of your favorite podcast sites. Now, I want to take a minute and introduce our distinguished guest. Jonathan Bandell is Vice President of Strategy and Innovation for White Plains Hospital. He oversees strategy, programmatic growth and development, and a venture fund incubator. Jonathan is responsible for establishing the innovation department's visions, goals, strategic imperatives, and investment. Jonathan has over 16 years of healthcare strategy and operation experience and previously raised a $5 million venture fund. Jonathan has a BA from the University of Pennsylvania, an MPA from New York University, and an MS in finance from Baruch College. In addition to being a fellow in the American College of Healthcare Executives, certified Six Sigma, Green Belt, and project management personnel. Welcome, Jonathan.
Very much. Happy to be here.
Dr. Zsolt Kulcsar is a medical director of the East Post Road Ventures LLC. He also serves as the section chief of rheumatology for White Plains Hospital. He is the medical interface that supports the identification and integration of new opportunities, innovation, ideas, and drives existing projects at White Plains Hospital, along with companies seeking to invest or collaborate. He completed his training in internal medicine for New York Presbyterian Queens and a dual rheumatology fellowship and preventive medicine residency at Dartmouth Hitchcock Medical Center. He also obtained a master's in public health, MPH, from the Dartmouth Institute for Health Policy and Clinical Practice, and went on to complete a master's degree in business administration at LIU Hudson. He has published research focusing on the intersection of technology and medicine in the area of telerheumatology. Welcome, Dr. Kulcsar.
Thank you, and it's a pleasure to be here with everybody.
Thank you. So our next guest is Dr. Mehrdad Shafa, is Chief Executive Officer of Medical and Healthcare Consultants LLC, a Nevada-based consulting firm specializing in management turnarounds and implementation of government programs. He has been involved as a chief medical officer and executive with multiple major insurance companies and health plans in Maryland, Indiana, Texas, Arizona, and California. He has been the clinical leader of quality improvement organizations and patient safety organizations in Michigan, Indiana, and Arizona. In addition, Dr. Shafa is Chief Executive Officer of Avicena Population Health Solutions. Avicena was founded in 2014 as a consulting firm that offers highly specialized products for population health solution. And Dr. Shafa serves as the Chief Medical Officer for Life 365. So let's go ahead and get into it. We've seen some major announcements in the previous months related to large telehealth companies partnering or being acquired by payers with huge market caps. We've heard the recent announcement that Amazon is launching their health initiative, starting with large employers. Obviously, this is going to start to have an impact to traditional patient care and the role of community-based hospitals. I want to start with you, Mehrdad. Let's start off with a foundational question. How do you define, and better yet, CMS define, hospital at home? Is this an official designation?
It is. It has become an official designation, Kent. Basically, it is care that is appropriate for acute hospital inpatient care. but is now being delivered instead of a hospital room in patient's residence or another residence. So literally, patient's residence becomes an extension of the hospital. So what it is not is the care that is being delivered in a skilled facility or long-term care facility. It is not observation care. It is not short stay. It is not hospital to home. It is acute care being delivered in patients' residence. Maybe it's an alternate residence, maybe it's assisted living or independent living, but it cannot be in a skilled facility, SNF, or in a long-term care facility.
So do hospitals have to go out and get certified? And what does it take to get certified to be part of that program?
It requires a waiver, and a waiver, there are two avenues to get the waiver. Basically, you must have certain programs and policies, procedures in place, or you must have treated certain number of people in order to be to apply for the waiver. However, what it is that very few number, if you think there are 460 acute care hospitals in the US, as of March 3rd, only 105 independent hospitals, unique hospitals had applied for the program. So you're talking 0.25% penetration rate at given at this moment.
I gotcha. So Jonathan, I want to skip over to you really quickly. White Plains is a very innovative hospital, right? I mean, obviously you have the venture side of it. You're bringing a lot of different technology in. Why bring the other technology in? What is White Plains' roadmap towards your vision seeing outside the four walls of the hospital to the home?
That's a great question, Kent. And I think it's really an extension of what we're seeing in other industry verticals. So consumerism in healthcare has been at the forefront or been discussed for the last 5-10 years minimum. But as we've seen, the Ubers of the world, Seamless, Netflix, people prioritize and value convenience and access. And those companies all have that same fundamental value proposition of providing what you need, when you want it, how you want it. And we're seeing in healthcare it's no different. Our patient, or in this case, customer expectations are evolving, and we need to be able to provide care where they want it, how they want it, and specific to whatever location that may be, whether it's a physician office, whether it's an emergency room, whether it's an urgent care. And this is just a natural extension for us to go into the patient homes and increase access and increase the touch points with our patient base in ways that they're seeking care. And it's really us trying to be at the forefront of that. And it's part of a broader strategy where we're developing an ecosystem that can essentially customize your experience with us and your healthcare needs.
So do you think they're going to be able to achieve parity from a reimbursement standpoint, that no matter if they're at home or if they're at the hospital, would you be able to bill the same way as you would if they're in the hospital or at practice that's surrounding your hospital?
Yeah, so that's the big unknown, right? COVID accelerated our digital health deployment strategy because all of a sudden there was reimbursement parity. Now, whether that's sustained or not remains to be seen. Obviously, our economic model does get materially impacted if we don't have that parity or if we're driving care in one modality or dimension that impacts another adversely. But right now we haven't had to worry about that. That's one of the positives of COVID, if there is such a thing, has been the fact that we have been seeing reimbursement parity. We don't know. We're still building our ecosystem because it's the right thing to do, and we'll figure out an economic model that works later on if we have to.
Okay, well, Dr. Kulcsar, I want to ask you, what kind of services can be provided at home versus in the hospital? I know you're not moving surgery to home quite yet, right, from that standpoint. But what services are you doing at home? What services do you look out, 3 years in the future, 5 years in the future, maybe 10 years? What role does the brick and mortar hospital play? And what services can you do at home to be an extension of that?
Well, I think that's a great question. We think about this often, right? We want to send somebody to the hospital when you need a specialized procedure where the monitoring or the equipment or the skill set, not necessarily of the procedure, but also the staff that are trained to monitor complications. And I think ultimately, You will still have certain procedures in the hospital. What we might see is that the stay after a procedure will be so much shorter because the hospital at home concept can pick up that monitoring and can do the routine things. And we all feel that recovery still happens much faster and much better in the home. And just simple things like confusion after a procedure in an older patient that happens in the hospital setting is bound to happen much less in the home. And you can really do that monitoring. So I think it's not necessarily what will be taken away from the hospitals, is that it will be a finite point when you get a procedure and the discharges will be quicker, probably safer, and it won't be a blind discharge that's happening now, which I would say once you're out of the four walls, we really don't know what's happening with you. Exactly. And you're phone called to death, but there's no data coming in. And I can't slap some monitoring onto a patient and know real time that somebody's having trouble, reach out to them and still keep them in the home or bring them in a controlled fashion. And I think that's what's going to really change with the advent of remote patient monitoring and the concept of hospital at home.
Does that involve sending resources though? I mean, does White Plains have a home health care side of the hospital, or are you looking to partner with home health care in the communities around you as well to send resources in the home if you need to?
So ironically, from what I'm told, historically, we actually did have a home health care partnership and we cut it loose back in the day. And now it's something I'm sure we would love to claw back, but a lot of people are also interested in that type of partnership. It's something that we have to move to. I don't believe it exists right now. We do have community partnerships, and I highlight a program where we really started our first telemedicine pilot was an IHI grant where we partnered with the paramedics that would go out to a patient's home post-op day, post-discharge day 1, then day 2, then day 3, and for 30 days on a cascaded scheme. And our ER doctors would actually jump on a live video call, be able to listen to hearts, lungs. These were the high-risk discharges. Some of them were going to homeless shelters and they would visit. But that was the partnership where we learned a lot, and we realized that these partnerships actually make sense. And it's interesting because the community partners want to do this. We asked our paramedic, why would you do this? It probably costs you more in gas to actually participate in this program than the grant paid. And they said, we see it as the future. And what was really interesting about this particular grant was the idea was there were lots of different ways to use technology and extensions of the hospital. And if one of them really struck a chord, CMS wanted to start reimbursing it. So the jury's still out of which one's the winning model, but it was very interesting from our perspective to be able to go into the home, to be able to do a home assessment. And it was in a frequent enough cascade that it was relatively real time. But I think the technology that we're partnering with does a much better job than still a blinded visit, maybe day 3, maybe day 7, whenever a paramedic kind of gets around to getting to that patient, or they get an urgent call, which I would say is too late.
Yeah. And to that point, it really is a process, right? We had to start with building the infrastructure so that someone was monitoring the data that was coming back. And if there was an issue, flagging it to either intervene or to connect with the attending physician to have them intervene. And that was sort of our first focus. Zsolt mentioned the grant. We sort of played around with that pilot, but we also learned we had to build the infrastructure back here so that we had someone monitoring the data as it was coming in.
Yeah, I was gonna say, as you know, we've got a great relationship with the AMR ambulance that's out there. And, I won't say this about AMR, but statistically, 70% of all ambulance rides may not even be necessary. 70% of all ED visits may not be necessary. Fire departments are turning into medical departments, right? And behavioral health departments, right? Instead. So there is a need to start taking these resources and turning the bus around and going towards the house and stabilizing. So you're seeing programs like Dispatch Health, right? Which is partnered with Humana and, MedArrive and Tele911 and a lot of programs where they have paramedics that are out there and using them to be navigators and baseline and stabilize and then connect them remotely. So Jonathan, where do you see the resources around, around White Plains? Would you utilize, the MAs and the PAs and staff within, the clinical setting to be able to monitor the patients, or is it somebody like an AMR or a third party that does that for you?
So we've already started that process. We've centralized and we've hired nurse practitioners and nurses. Yeah. We wanted prescribers to be part of that team as well. And they're working under the purview of our physicians to say, essentially, develop your care pathways by clinical area, by service. We said, what are we treating? What are the diseases we're targeting with these technologies? And give us your clinical pathway. So if there is an issue or there is a flag, how do you want the NP or the RN to intervene? And then how do you want them to communicate that to you as well? So we've already started that. It was, like I said, it was important to have prescribers as part of that team, but that's how we've decided to build it. And there is a physician who ultimately oversees the entirety of that program.
Yeah, it's interesting. I remember, this is probably 10 years ago, from, this little known hospital system in St. Louis called Mercy Virtual, right? That's out there that, it's not little known anymore, but, going through and actually saying, we're going to clear out the four walls of the hospital and put clinicians in potentially, and we're going to connect to the community. And that's exactly what they're doing. Yes, they do surgery still, they do day surgery, they do, critical care patients, but the majority of the patients they're servicing are community-based. They're stabilized by probably a nurse practitioner or a paramedic, right? And then they're monitored from Mercy Virtual call centers, right, from that, which makes a lot of sense. So it sounds like that's kind of a model that you guys are maybe thinking about experimenting with or moving towards.
Yeah,
right?
no, absolutely. Ken, I mean, really our program was born out of a need, and it was one clinician who just retired, but it was really a great story when we had an aha moment. It was an allergist immunologist who treats asthmatics from the youngest age to the oldest. And she said, these COVID patients, and because of COVID, nobody wants to come in. And we can't do in-office nebulization because they'll spread the disease everywhere in the office. So I don't know what they're doing at home. I can't guide their nebulization. I don't have spirometry. I don't have O2 sats in the home. It's all blinded, and we can't bring them in. And often I would just give 2-3 treatments, and a tight asthmatic could go home and not be admitted to the hospital. Now they would come in very critical condition. So the idea was, if we can get data to these clinicians and we can guide the treatments and do some frequent video visits, you can keep people in the home. And then also you start asking, well, why did we even bring them in so often? Because you really only need to bring them in once before you make a critical decision of, do you put them on steroids and antibiotics? But you don't need to bring them in to nebulize in the office. That can be done easily in the home. And so that's where the idea was to start with pulmonary and the respiratory care, and then it just needs to go into other areas.
Yeah, and piggybacking on Zsolt's point, that was another learning we had from our whole COVID experience as we scaled our telehealth platform, was that video was great. It was obviously a better alternative to foregoing care, not as necessarily good as being in person because it was limited in terms of what we could do and the data we could extract. And so when we had what I'll call a slight lull in our COVID curve, because being in New York and Westchester County, which was the original epicenter of the US, we were sort of a little bit ahead of the rest of the country. We took a deep breath, reset, and met with each of the clinical chiefs and medical directors that we had and said to them, okay, debrief your experience with the video health platform. If you could extract certain data elements, what would they be to enhance the quality and the utility of your visits? Don't tell me what cool device you saw on TV or through your medical society. Tell me the data element you want, and we'll source the technology that meets that need. And I think that was incredibly informative for us and useful for us to build this ecosystem around actual needs, not of perceived needs because of the cool toy or the new buzz item. So I think that was invaluable for us as well.
Yeah, Mehrdad, I want to go back to you really quickly. On the CMS side of it and hospital at home, what are the expectations from CMS about services that can be or need to be provided into the home to be able to qualify or certify for that program?
Well, CMS expects all the services that are provided in the hospital to be able to be provided in the home setting. And that means your clinical monitoring, food, DME, supplies, medication, etc. So whatever that is needed for, I have to go back. There are limited number of conditions that are currently on the list. You know, the usual suspects, COPD, CHF, cellulitis, etc. And these are not, but the most common conditions that bring patients into contact with care delivery. But your expectation is that you have to do exactly the same. Now, the remote monitoring, I would like just to touch. I believe CMS is going to evolve this as, learn more about it. It can be as crude as 2 sets of vitals a day. It can be that somebody, it cannot even be, it could be even not in person, somebody goes and checks it and faxes the information in, or it could be continuous monitoring. So it all depends on how the system is set up, how the infrastructure is, what is your staffing. And I'm glad to know that you have your dedicated staff, because I believe this is going to be one of the areas that is going to hurt everybody. If White Plain goes and hires staff, then there will be a shortage of people who could provide this service to the rest of the community, etc. So CMS has this habit of dangling a carrot in front of people and says, we're going to give you some money, get involved. Within 2 years, it becomes standard. And in 2 years, if you don't participate, they're going to penalize you. So I have seen this, and I predict that there's going to be the major driver of this is going to be CMS, and then other commercial payers and self-funded employers will join the bandwagon. We will see a lot more of hospital at home, and with evolution of telehealth and a more advanced PEG system. I mean, we will see a lot more of it. Dr. Kulcsar just mentioned, why didn't we think about testing saliva for rheumatological conditions? I believe pay was an issue, how would you pay for this? And we didn't do hospital at home because there was no pay mechanism for it. But once the pay mechanism has been established, I think the floodgates are going to open.
Dr. Kulcsar, I wanted to go back to you really quickly. Maybe Jonathan as well. How was adoption of telehealth? How did the doctors go from 0 to 60 at White Plains when COVID hit back in March timeframe? And where does it sit today? Can you hear me? Or
Sure. I mean, it was a fascinating thing. So I came to the institution about six years ago, and I've been kind of preaching telehealth to everybody, and they're kind of like, that's great technology. It's nice, stand back. A few pilots took off. And then literally in 10 days, when COVID closed all of our offices, one of our busiest hubs was literally half a mile from patient 0 in the Northeast in New Rochelle, and it became a containment zone. So our primary care and specialty care was just shut down from one day to the next. And it was interesting because I remember one gastroenterologist who said, everyone in that office got trained, and this one person was a little bit of a holdout. And as 2, 3, 4 weeks went on, and they realized this is something that's not going away, it's changed practice forever. We got the call and the email, I need the training, I need to start doing this, I need to provide care. And it literally went from one day to the next that we had 100 visits in a few months to hundreds of visits in days and to thousands of visits. And so it really took off quickly because, in our instance, our offices literally shut down and there was no way physically to even get into the office. I mean, the National Guard came from New York and created a containment zone. Wow. And if you put a pin right in the middle, that was our office. Wow. So there was no greater opportunity for telehealth than what we got. It was a gift for us. So I guess
good.
The part two was Jonathan and I literally took every single type of billable visit that ran out of our 350 physician specialty group. When that lull happened in COVID in the midsummer, and we guesstimated what services will continue telehealth, what will come back in person. And we landed at a really strong guess of about 20% of our services will go to telehealth and stay there, and then the rest will come back in person. And that's actually played out quite nicely. We were fairly on point with that. About 20% consistently remain telehealth.
And you see variation based on specialty, obviously. And just piggybacking on what Zsolt was saying. So that is actually a fact. We had to train all of our providers, as Zsolt mentioned, about 300, 350 in a 10-day period. The day after the governor brought down the National Guard to establish the containment area, we had to cross the containment zone to go into that location to train people. So that was fun and interesting. But one of the dermatologists at that site made a comment to us while we were there saying that telemedicine single-handedly saved her practice. Because we did shut down the offices. At that point, there was a lot of unknowns around this disease and we couldn't risk people coming in at all. And so we went 100% digital. Yeah.
So you got the doctors used to and the staff used to telehealth, maybe welcoming it, or maybe kicking and screaming. We don't know. Maybe there's some either way. But what is their attitude towards the patient now being someplace else, right? Not just a telehealth visit, but an ongoing relationship with the patient being, at home from that, and preparing for the patient and trying to fit into their clinical workflow, the ability to go, not have physician fatigue by getting alert fatigue and everything else with that as well, but being able to care for a patient that's outside the home.
So one would argue that historically they should have already been doing that, right? You're getting phone calls from these patients when they're proactively reaching out to you. There's some ongoing relationship and they're not in your office all the time. They're there for a fraction of the time. The alert fatigue was a legitimate concern of ours, which is why we've also built this infrastructure around the nurses and nurse practitioners so that at least the notifications are going someplace else first before they get to the physicians. And it's only when it gets escalated that it gets to them. Because obviously they're inundated, and Zsolt can speak to this better than I can. I mean, the Epic inbox fills up constantly, and to the extent that we can try to decant some of that appropriately makes sense. And it's something we have emphasized, because in addition to being patient-friendly, we want to be provider-friendly as well. Zsolt, you probably want to talk about that before I continue.
Well, when I think of alert fatigue, I think of it in two ways. There's kind of the regular day-to-day office visits and telemedicine visits, and then there's the remote patient monitoring program. As far as the day-to-day goes, COVID again gave us a gift. Now it opened up telemedicine video and phone call visits. So if somebody calls with a rash, now there's a mechanism, and we built the EMR. When we said we launched telemedicine, we had a vendor in place. They were going through the accelerator. All of these blocks were in place. We just had to institute. And so we optimized our EMR where there are new slots and new modalities where the front end could just put people in as they needed. So it was actually more convenient for our clinicians, and they didn't have to make a phone call while chewing on lunch and typing a note in the other hand. They actually had these slots that people could comfortably be blocked into. And they also told us they're shorter visits. It's really easier to kind of cascade down a phone call video visit as opposed to when somebody's glued into the chair in front of you in the room. You're holding the handle on the door and there's by the way, another question. So I think telemedicine in that sense had a natural cascade, shorter to the point, and we got it done. Now, as far as remote patient monitoring, those alerts don't go to our clinicians. And the way we've been able to sell it, package it, and there's significant buy-in from our clinicians is, think of a pool of patients that you personally worry about. They're your tougher COPDers, your tougher asthmatics. Put them into the remote patient monitoring pathway. There's a nurse who will engage with their data, and there's a nurse practitioner who will engage with them to a certain point where you're comfortable, and then they will escalate it to your schedule, either in person or video visit, however you like, and whatever type of problem they might be raising. All the data goes to the nurse and nurse practitioner, And only if there's an escalated visit to the clinician does the data get packaged, PDF'd into Epic before the visit. And then the clinician now has the whole patient packaged. They know their O2 sat, blood pressure, they know their spirometry, and they know why there's a visit because there's an in-basket note before that visit. And so we packaged it as you probably avoided 3-4 phone calls from that patient, and now they're appropriately on your schedule, and you just have to make a decision in their care.
Yeah, and real quick, sorry, Ken, real quick to piggyback on what Zsolt's saying, because I'm going to put Zsolt on the spot in a minute. In terms of current state from a scheduling standpoint, so getting back to being provider friendly, we've sort of deferred to the provider preferences, whether or not they want to have a block of their schedule for virtual visits. And this is, the first 3 hours of your day, you're doing virtual visits, the rest are in person, or if you want to intersperse in person and virtual, completely at the discretion of the provider with what they're comfortable with. When we put Zsolt on the spot, he told me an interesting anecdote once that resonated in terms of an unintended consequence. Talk about alarm and alert fatigue. But what we found from the virtual visits, particularly when we were going through the peak of COVID, was that our providers, although the appointments were shorter, they were essentially more intimate and more grueling and taxing. And Zsolt, you mentioned that good story, and I think that it's interesting enough that you should share that.
Yeah, it was really fascinating because one of our internists was speaking to a patient where they lost 2 family members, and they were grieving in the home, and they had a general internal medicine follow-up. And he said this was one of the most emotionally taxing interactions he's ever had with a patient, because he was in their home. He saw their setup. He saw their grieving process. He saw their family in the background, conduct the medical care that needed. And really, they told, I love the modality. It's convenient for my patients, but it's exhausting. But, this is also in the middle of a pandemic. But a lot of clinicians also said they picked up clues and cues they've never seen before about their patient because they were now in the home and they saw that video.
Yeah, that's one thing I always insist upon myself from my chair, is that when we deliver a new product at the very beginning, I personally go out to the home, not even my staff. I personally go out to the home and work with the patient to install it from that perspective and see how they really use it. Right? When we were installing our previous company with Cleveland Clinic, Best Buy was trying to go in and make installation of setting up blood pressure devices and scales and feeding it to Microsoft. And it was taking 8 hours per visit for Geek Squad. Because guess what? When you came in, the 80-year-old patient that had congestive heart failure didn't have state-of-the-art computer equipment. They're running AOL and they're running old computers, and if they had them at all. And so every home, if you've seen one home, you've seen one home, right, from that perspective. And so you've got to bring in solutions that actually are free of their infrastructure and free of their environment, and they're just hands-off and can allow them to communicate right from that.
So I'd like to add that now that you have taken hospital to home, what it is in front of you right now, as Dr. Kulcsar said, patients home, social determinants of health that have been always neglected or ignored, now they must be addressed. You really need to, if you want to manage the person, a lot of people's residences are not safe, are not appropriate for care. So hospital home is not for everybody. But what you really need to is get a good look at what is happening inside, what is the support system, what are the finances, what is the availability of reliable transportation back to the office, what is the health literacy that you have worked on, how is it being applied in the home situation. So now telehealth, in my opinion, the new frontier for that is moving from episodic care to managing the whole person.
Yeah.
It is managing the entire social determinants, physical behavior, what we used to call years ago, biopsychosocial model. Now we call it population health. And now telehealth needs to get engaged. Fortunately, there is a pay mechanism for that. CMS rewards and pays for the case management services. But absent that, it would have never happened.
But Mehrdad, it actually is being asked for by the payers, right, as well, right, and by the individuals. They want to be seen as not just as a diabetic. They don't want to be seen just as a congestive heart failure patient. They don't want to be treated just for hypertension. Maybe they need to be treated for sleep apnea as well. You've got to see, potentially the whole person, right, in that
Absolutely.
situation.
Many years ago, I'm just going to use one anecdote that looking at what is a patient's environment is and what is happening. I had one child that was in ER every other night with an asthma attack. And parents were reliable. There was no smoking at home, had full allergy evaluation, everything that you wanted them to do, what they were doing. But this kid was having an asthma attack every other night. So I had hired an asthma educator in my office. And so we just got in the car and we drove to the person's house and just parked in front of the house, and we made the diagnosis. This family lived on the second floor of a hair salon. And what had happened that the exhaust from the hair salon had been erroneously connected to this child's bedroom rather than to outside ventilator. And every night this child had an asthma attack. So had we just had access to this to this system, we would have picked up on the patient's symptoms far, far ahead of time before, had 15 ER visits per month, and then you have to go and manage the patient.
Hey, Jason, I want to get into, I want to ask this question before we run out of time. How are the telehealth companies going to be a partner with you, or do you see them, the big ones that are out there? I mean, when I talk to CEO of health systems right now, they have to make some decisions. Do I build another $1 billion complex, right, that's out there, or do I start distributing clinics around, and do I start, doing more telehealth visits and more remote visits? Because right now, the telehealth companies are coming into your community and taking your patients, right, to be able to take care of for them. So how do you view them, and how do you partner or counter them?
So I think the value prop that we offer that they don't is that we do ultimately have that brick and mortar. So when those patients have an issue and, they're being seen by, use Teledoc as an example, not to pick on them, but knowing that they have their whole physician infrastructure as well, they're going to have to end up someplace. And the value prop we can offer is that continuity of care here as part of our telehealth platform and offering. So that I think is a critical differentiator. It is case-by-case basis where we think we should partner versus compete. But our strategy is multifactorial, where we are looking at service expansion, opening new locations for a variety of services. I mean, it's no different than, let's use Amazon as the analogy. Amazon drove out retail and brick and mortar only to acquire Whole Foods and now open up their own brick and mortar bookstores. So,
yep.
There's always going to be use for both. And I think that's what differentiates us from those technology companies that are ultimately technology companies first that now have physician practices as part of it.
Yes.
And for the hospital at home program, the patient must be between 30-minute transportation time to the hospital. So Cleveland Clinic cannot come and get their patients. Patient must be connected within the geographic area to the hospital.
That's a good point, because I was going to ask the question. From a community-based effort, there are people coming from around the country that are coming into your community to take patients or deal with patients. Do you see yourself servicing, other people outside of your community?
The short answer is right now, no. I think part of what we've been successful with is scaling as a community hospital now into a tertiary care hub of a region. With the only caveat being, we do have a significant population of snowbirds. So we have looked at, no different than our competitors in the area, what that could look like to provide virtual care to our patients who are relocating for a period of time to Florida or to Arizona, wherever the case may be, so that they have continuity and some stickiness to us as well when they do that. So that's something we're looking at. But broader than that, not at the current moment.
So Dr. Kulcsar, who would you consider your necessary partners that are out there? I'm not looking for an answer of Life 365, by the way, because that's a given. Who would be your necessary partners that are out there to make a successful at-home program? I mean, are you talking about a meals partner? Are you talking about a transportation partner? Are you talking about a home health care partner? What kind of partners do you need to be successful?
I think you touched on a lot of the points. You really have to start figuring out exactly, often we start with a population. You don't want to just start and try to treat everything. So you usually do some search and realize, okay, this one disease state is what shows up frequently and is very nicely applicable to a hospital at home. And then you start building that program and realize transportation in my mind and pharmacy type of services are necessary. And then really the nursing staff, the nurses that can go and do the in-home assessments, and you can rely on other agencies. It may be something that you want to bring into the fold eventually, because it's going to help you build that program and scale the program a little bit easier. It's also very difficult to get some of the partners' attention solely focused on what you want to build if they're really trying to service many different systems in the area. But in my mind, I can't imagine a successful program without the visiting nurse piece and without medication and transportation as just pure basics. And clearly, what you also want to build is a new mindset of your clinician staff. So that not all doctors will to do this. And we struggle with that question of literally there were clinicians that were not the greatest bedside manner in person, but were fantastic on video. And it was almost like an aha moment for them. Like, this is your calling. Like, you really do much better with a telemedicine encounter than in person, and vice versa. And so I think you have to also pick and choose your clinician, not just your ancillaries around the hospital at home.
Okay, so you kind of touched on this just a little bit, but I kind of want to go back to the pharmacy really quickly and talk about the pharmacist. Med reconciliation is probably going to be a big thing, right? From this as well, to make sure they're taking the right medicines on at the right time. And if it is a 30-mile radius or whatever, do you see White Plains being more engaged into playing the role of a pharmacist and delivering meds and doing med reconciliation? And on the flip side of that, from what role do you think the pharmacist could actually play in community-based care with your programs, if anything? So I'm curious.
We actually don't have a retail pharmacy like a lot of the large health systems do. But I definitely think that's a service that's valuable that you could farm out and would be important. And I recall working at the VA in White River Junction in Vermont, ordering something as the medical on duty supervising fellows and residents. A pharmacist from Missouri called me and said, nah, there's one interaction. We're a national system. We know this guy took something 2 weeks ago, big interaction. You're going to have to switch it. And it was a lifesaver for that gentleman in the ICU. And I think those are the services that are necessary once you start doing hospital at home. And a lot of the health systems really own this data. And we know what medications were started and stopped inpatient. If you partner with local pharmacies, get a little bit more synergy and more clarity around those medications, that's going to be important. And we are actually piloting telepharmacy. And we're still kicking around, is it valuable, or is it yet another person telling the doctor via an in-basket message that they should be doing something differently when we've already bypassed some of those alerts naturally because we know them, our EMR flagged them. I say, again, alert fatigue is a problem with the telepharmacy program, but if it saves a life, that's also a very important program to be running. So, I'm a little torn with the pharmacy programs, and I certainly see the value because we are doing pilot and it's a necessary thing. And I've personally experienced almost having made a mistake like that, and a telepharmacist really clearing it up for me.
Awesome. So, Jonathan, I'll get your name right this time.
It's my brother. It's fine.
That's okay. There you go. You can call me Kurt if you want. What role do you see as, faith-based organizations within communities, playing from that as well to kind of support populations, right? To help you? Have you even thought about that type of concept, from it? Or is this a direct relationship to the patient to the home to White Plains, right?
So
Do you have support groups that are out there?
Yeah, for the most part, we are doing mostly is direct relationship with our patient population, but that's not to say we haven't engaged the appropriate faith-based organizations or other nonprofit type entities that have involvement in our patient populations. A good example, we worked with the local church to do COVID vaccinations, to get into the community for distribution in a way that we couldn't, and they've got that trust that you're essentially leveraging in order to deliver that service. I think we're open to everything, but our focus right now has been on what can we do better to improve our direct relationship with our patient population. And we've been complementing that with other organizations as it makes sense, including that telepharmacy pilot that Zsolt was talking about. Obviously not a faith-based organization, but it was an example of where we could partner to better deliver care to our patients.
So what role, and let's staying with that for a second, I always talk about the pharmacist and going into small rural locations, and they've got to have a payer. So let's go with a large self-insured employer. And then they have a small regional health center that's there kind of partnering together. And the pharmacist is kind of the watchdog over it all. Do you have partnerships around large self-insured employers and their employees in the community, especially but caring for the retirees who could be the biggest, expense, right, in their population, right?
Yeah, so to date, our direct-to-employer agreements have focused more on current workforce and how we provide care to the current workforce for these large employers that are in our region, inclusive of ourselves. We self-insure, and we're a large employer in our market, as well as most hospitals and health systems are. So how do we manage the costs associated with the current employees? Retirees, not so much, because again, given the region we sit in, most of the retirees are now sitting in Florida. So we're challenged for sure.
Yeah, they don't want to be in the snow. So Mehrdad, let me ask you a question. You've been around this a lot. What obstacles are going to face health systems that are trying to go, White Plains is a different type of hospital, an innovative hospital. I'm sure they want to have the same obstacles, but what obstacles would you face, right, going into home?
I wouldn't call them truly like an obstacle, but these are the issues that should make you pause and have a deliberate conversation and evaluation. First, let's go with patient's preference. We have noticed that some older patients, they'd rather be in the hospital rather than be in their own home. They do not, for them, sometimes it's more pleasant, more interaction with other humans that are there. What we're missing, the issue of clinician training is foremost in front of me. We don't teach this thing in medical school. Very few residents have had this type of training to be in the community and combine that at the same time with telehealth. Issue of safety at home. Again, safety of the providers that are going in people's homes. CareMore had a model a few years ago that, clinicians all had this panic alerts. They could push the button if they felt their safety was jeopardized. Another big issue is quality of care. At this moment, there's no defined quality of care parameters. The only thing that I could find was the quality requirements of home health through Medicare, that you must just provide adequate number or measures to do that. The other thing is staffing needs. We just talked about it. Hospitals don't have extra people sitting around. You have to go and hire the nurse practitioner. You have to outsource with the other pharmacy or infusion system, or hire the nurse practitioner or transportation company. Data integration becomes critical for all of these, and managing social determinants of health. This is the area that I have really found out that, of the readmissions, when we did analyze an incredibly large database, 70% of readmissions have one element of social determinants, 50% have two. And as long as we don't manage the social determinants, and we have to manage it now through telehealth and telemonitoring. So these are the big issues I think we have to address.
Dr. Kulcsar, we're going to have to wrap up here in just a few minutes, but an hour goes by pretty quickly. It's interesting when we've had this discussion, I think, ourselves, and talked about who would actually, pay for the services. And I threw a poll out there, kind of asking the audience who would pay for stuff. Interesting enough for me, if this is an option available when I moved my parents from the farm to independent living, if they could still have had access to a service like yours connected to the hospital system and be monitored remotely, we would have paid for that out of our pocket, right, to do that. And 63% of the participants said they would be willing to pay for it, right? 63% on telehealth, 56% on remote patient monitoring, and 50% on home care, 56% on food. The other question that kind of came out too was, are you comfortable in coordinated care with staff members that are in the clinician's office and work directly for a clinician, but it's not the clinician, right? And the answer is 88% said yes. The other one, 81% said that they would actually be comfortable in talking to a health system that was outside their community, right, to be able to do that. So I guess people are already doing that, with Teledoc from that perspective. And then the top things that obviously people want in the home from that standpoint are telehealth, remote patient monitoring, in-home care, and then med reconciliation delivery from that, and then potentially behavioral health and wellness and exercise programs, right, as well. So I know we've got, a few minutes left, maybe 5 minutes left. Dr. Kulcsar, why don't you tell me, exactly, what White Plains is, the first thought of going and connecting the home. What do you think that you can start with simply, right, as an exercise to start the program with a hospital at home with White Plains? What do you think what do you think the best condition is, right? COPD, asthma, congestive heart failure. Is there something that White Plains has started with to start simple, or does it have to be all the disease states?
So, really one thing that you mentioned, in our community, we're next to one of the wealthiest zip codes in the entire United States. It's literally spitting distance from our doorsteps. And we have actually people who would pay willingly for this program. They would forego the RPM codes. They'd pay a monthly service and just give me the kit and get RPM going because I'm engaged and I want to do this. We've chosen to use pulmonary conditions as number one, COPD, asthma, especially with the partnership with Life 365. And we look to go to endocrinology and also cardiology. And the reason is, again, a lot of our patients have the Cardia device. They come in with these tracings and readings, but it's also episodic. They sit with our EP cardiologist every 3 months and review it. Why not do it proactively? Exactly. And I know you guys integrate that. Yep. So, we can't really do it all. And we're not necessarily dipping our toes just yet into the hospital at home where we do rounding and daily progress notes on patients as if they are in the hospital. But with the RPM, I think that's the next natural step because we're gathering so much data. Things happen with the data. We're going to interact with the patients. It's already the appropriate level of clinician. It's an NP. So most likely it will be COPD and then CHF care where we will start doing this. And it may be somebody who has an initial evaluation in our ER. We don't admit them, send them home, send them on monitoring, and put them into our program called White Plains Hospital or WPH Cares, where all of these services sit in a centralized location using the Life 365 platform. COPD, CHF, and endocrinology are the next natural steps for us. And those are the areas we're identifying the patients. We're identifying some that are CMS. You can just go ahead and give a kit and bill. And we're also in a parallel track identifying those engaged, wealthier patients that are just willing to pay out of pocket because they want the service. So we really are doing both.
With one caveat being, so long as they fit the criteria. We are staying disciplined to ensure that we're not just selling these or offering these to everyone who's willing or wants to pay. Because what's going to happen is you're going to get inundated with the worried well. And then all of a sudden our infrastructure is going to have limited bandwidth and capacity, and we're going to miss the critical data points that we need from the actual patients who need our care and our intervention. So we are staying disciplined to ensure that it's being given to people who require these services and not just anyone as a result of that.
And I think you guys have done some real mindful thinking about, you know, the home versus the clinical setting that's out there, as far as, you know, that the readings and the data that's coming out of the home are merely trying to look at warning signs, right, or compliance from that. And if the warning signs are out of boundaries some way, then you bring them in and do more of a clinical evaluation on them, right? From that standpoint, it's hard to move the clinic to home, right, to be able to do that, but it should be really about you're putting guardrails in and looking at early warning signs.
Right.
You can have early intervention so they're not showing up in your ED. Right,
and as you know as well, to that end, patients who we consider to be of the high risk category, we're looking at passive remote patient monitoring devices as well. So we don't have to necessarily rely on them to do something actively, but instead we can extract or extrapolate data parameters off of devices without them having to do anything other than live their lives. That way we can certainly know when to intervene when appropriate.
So Jonathan, where do you think you're at in 5 years as far as percentage of people that are coming in the hospital versus people that are community-based patients?
So I
think, growth rate.
So it's an interesting question. I think as we've continued to evolve in our journey as a hospital, as a tertiary hub, we're expanding scope of services. So I would argue that we would be 5 years from now decanting superfluous admissions that were more readmissions for something that, you know, happened during that 30-day window, and instead replacing it with cardiac surgery, which it's public knowledge. We have a CON now. We're launching cardiac surgery later this year. So I think it's like Zsolt mentioned, it's about having, we're always gonna have a hospital, and it's always gonna provide surgical care, emergency care, ICU care, and it's gonna be the population in our census is gonna be more of those and less necessarily medical admissions, which we can treat at home instead. So I think we will see growth in both areas. It's just gonna be more of a transition or a transfer of certain types of care into the home while we backfill with other more types of acute care in the hospital.
Okay, that sounds good. So Mehrdad, just a minute left or 2 minutes left from that. What words of wisdom can you impart? Not the obstacles, but words of wisdom for a successful program.
Well, successful program starts with patients' needs. And if you want to just build something, we can't just duplicate what was happening in the hospital. You have to just go in the community and find out what it is patients' needs are and what is available, and then coordinate those together. For me, what I see right now, the availability of infrastructure, most hospitals that have hospital at home program, their volume is between 3 and 5. Rarely they have more than 7 per day. And because you don't have enough people, there's finite amount of hours in a day for a nurse to travel from one place to the other. But with AI coming in, with improvement in technology and computing, then I think you will see a lot more of patients moving to their own residential settings, and hospitals being more of a specialty places that you need surgical subspecialties or rheumatological services in person rather than tele. That's what I see it's going.
Great. And Dr. Kulcsar, any parting words for us about your program?
Yeah, I think, again, COVID gave us a good lesson that we should not forget. During COVID, people called us, and we couldn't just tell them, go to the ER. That had to be a very guided process, because either they would be exposed because they had an immune suppressed state or cancer, and you just did not want to throw them into the trenches, or they called because they had COVID and we didn't want to expose our staff. And so really we needed the monitoring in the home to guide that process, know when it's time to come in and when it's time to stay in the home. And now the monitoring will do that. Even when COVID goes away, we just still want the appropriate level of care. We want people coming in at the right time and staying out at the right time. I think that's what RPM and hospital in the home will afford us.
Jonathan?
Man, I'm glad I surround myself with people like Zsolt who are smart. That's really my parting words. Yeah, it's about, I second what Mehrdad said in terms of understanding your patient's needs and what they require, and making sure you tailor your solutions to that. Don't create problems. Instead, find solutions for problems that you have and validate.
It's great. So I think we could go on another hour from this, but we're not going to, so because people need to get to dinner. But I want to thank everybody for attending this evening. I want to take a minute to thank our distinguished panelists, Jonathan Bandell and Dr. Zsolt Kulcsar, and Dr. Mehrdad Shafa for your participation and great insights into hospital at home, increasing access to care. I'm sorry that we weren't able to get to any questions tonight, but we will post the video on the Light 325 Health and at www.newnormal.buzz website, as well as the recording tonight's webinar will be on Apple and Google Podcasts, Spotify, and many of your favorite podcast sites. So please be safe and healthy. We'll be on 2 weeks from now on March 31st at 1 p.m. Pacific time. I'll get it right. We're gonna have an earlier show, 4 p.m. Eastern time, where our topic will be 2021 remote patient monitoring reimbursement codes with Robert Jaron, Brian Scarpelli. These guys do a lot of work with the AMA and the government, and Kendall Paulson from Light 365. In addition, Dr. Kulcsar and I will have a fireside chat with Plug and Play Health the same day at 8 a.m. in the morning Pacific time, talking about partnerships, transforming healthcare with Light 365 and White Plains. And that's on our website as well, so you can get a link to it. So thank you for your being a great panelist tonight and audience, and have a great evening. Thank you.
Thank you.
Thank you. Thanks.
Thank you.